I got 1 o'clock Eastern, so let's go ahead and get started. Hello, everybody. A lot of you have got a glimpse into the panic that goes into getting one of these webinars going ahead of time, so we apologize for that. Welcome to implementing a remote monitoring program in a rural health clinic with VitalSync Health and ThoroughCare. So we appreciate our partners on this webinar to give you some information that's going to be very important to you. This is not in the slide handout. I just saw this 5 minutes before I got on, but I thought, oh, this is amazing. An estimated 70.6 million US patients, or 26.2% of the population, are expected to use remote RPM tools by 2025. That's not that far away. And so you can see what a big market this is. I myself, I have chronic heart failure. I should probably be on a remote monitoring system. So next time I go in to see my cardiologist in a couple of weeks, I'll probably asking him, why aren't I on remote monitoring? I have AFib and high blood pressure and a million different things. You probably ought to put me on remote monitoring as well. So that's why we're doing this seminar or webinar, because this is going to be so big. And thankfully, CMS has put together something for rural health clinics where we can provide a valuable service to our patients that is needed, and we can get compensation for it. So the agenda for today, I will try to talk only 5 minutes. I'll probably go over that if you know me. Dan Godlove from ThoroughCare will give us a 10-minute update. Remember, a bunch of you were here for our webinar in February, and Dan gave us a great presentation on CCM. Since that time, CMS has put out a fact sheet that sort of, I think it may have changed a little bit about the way we thought about what bucket to put things in, but Dan is going to give us an update on that. And then Levance Northington and Sabrina Martin from VitalSync Health will be telling you guys how to implement a remote monitoring program at your rural health clinic. You're probably like me and don't have any idea how to do that, but they will give us the best way to do that and show you a little bit about their product that can help you implement that program. Throughout this session here, Trent Jackson from our office will be running a poll question about every 5 or 10 minutes or so. If you want credit from the National Association of Rural Health Clinics for being a certified RHC professional, please answer 3 of those questions, and you have to watch it live in order to get credit for it. And then reach out to Trent, and he will send you the CPE certificate that you need. In the future, we'll probably ask that question on the registration. Do you need that? And then we can send it out automatically. We're brand new to this program. It's a brand new NARHC program, and so we've had it's a learning curve for us and for the NARHC on how to do this the correct way. So I apologize for any hiccups we've had getting this so far. This is the HBS team. This is our little advertisement piece to this. Myself, Danny Gilbert, Paige Chambers, and Trent Jackson. Most of you know my planned retirement date is October 31st of this year. So Danny will be taking over. She's bought the company, and Paige and Trent, you're in good hands with the team that is there. So I may hang around a little bit and do a little bit of, they may send me out on a faraway place and do a mock inspection every once in a while, but for the most part, I'm probably gonna be lazy. Here are all the services that we provide. Cost report right now. If you've not got your cost report information in, get it in. We are full-blown cost reporting. May 31st is the deadline for our 1231s. That's really all we're thinking about right now. The other stuff is on the back burner as far as that goes. If you've not joined the Facebook group, please do that. We have 5,100 members, and it's very active, lots of information. It makes things happen like this webinar. This is a big reason why we're having this webinar today. We do have a new YouTube channel, thanks to Trent. Trent put together sort of consolidated a couple of YouTube channels we had. Now we only have one, and there is a new presentation on here about how to gather your documentation that Trent has done for you. It's not on this slide, but if you go to this YouTube channel, everything that all these webinars that we've done for the last 4 years are on there. So you'll find just about anything you want to know about rural health clinics there. And this disclaimer, everything is current as of today. You can watch this session later on. You're not going to get credit for it if you watch it later, but you can watch it later on. It will be on that YouTube channel that we just showed you. And VitalSync and ThoroughCare are the ones that are providing the content for today's session. So here's what the certificate will look like. And if you need it, reach out to Trent at his email address there. If you have questions, you can put them over in the box there, and we will give you some time at the end to ask questions as well. The slides and recordings will be on our website at ruralhealthclinic.com. Also, the handouts are over in your handout section there. If you want to pull those up, you can do that as well and follow along with them. About our speakers, our first speaker will be Dan Godlove from ThoroughCare. You probably know him from the National Association of Rural Health Clinics meeting. If you were in San Antonio, he was there, gave a great presentation there and about chronic care management. Him and ThoroughCare have been the leader in the rural health clinic space as far as consulting companies that have been helping rural health clinics implement chronic care management for a long time. You know, Dan's been at this since 2013. So he's going to talk about 10 minutes about the changes or the different interpretations from NCCM from what we thought it was in February. And then Levance Northington is CEO from VitalSync Health. He's been doing this for 2 decades. You can tell he's been in Medicare and healthcare for a long time because he got together a device called SoberLink. And if you've been in healthcare any amount of time, you definitely need SoberLink because Medicare will drive you to drinking. So Levance and his group have a great system that can help you implement remote monitoring. And then Sabrina Martin is here as well from VitalSync, and she, value care. That's the big buzzword. You know, everybody wants to be doing value-based care by 2030. That's Medicare's goal. She's got lots of experience in that. So Sabrina will be sharing her information as well. And then this is sort of an unexpected slide. At the very last second, I thought, well, I'll add this just in case, because this is something unusual in that Sarah Holman, y'all know Sarah from the National Association of Rural Health Clinics. She's the Director of Government Affairs. She told me something I didn't know, which is pretty easy to do. She's the copay on the GO511 is the lesser of the patient charge or the payment rate. And my guess is the payment rate is now $72.90. This thing's been changing like a ping pong ball. Every time I look at a Medicare rule or something like that, the numbers, one time it's $71.94, and then it was like $71.92 or something like that. The number I saw this morning was $72.90. So Dan, you can correct me if I'm wrong, because it tends to be changing. But the key to you to know is you're only going to collect from your Medicare patients up to a maximum of that rate, because you're limited in that co-insurance that you receive up to that amount, which is different than you normally bill. So just keep that in mind. I was looking at an EOB there. You can see where they only received a $14.34 copay, and that didn't make sense to me. And so Sarah told me what the problem was. So that's all I have, and I did 9 minutes. I was only 4 minutes over what I should have been. So Dan, I am going to now, let's see here. Whoop, nope, that's not it. I'm going to transfer this over, and you are now the presenter. So you should be in your bulk order.
I'm sorry. On my side, I just want to make sure it's showing that the attendees are on hold and it hasn't started in the top right-hand corner.
It's showing what now?
that the meeting hasn't started and attendees are on hold.
What?
Yeah, that I just want to make sure before. Sorry, I didn't mean to interrupt, but
Yeah, no, I don't know. Danny, is you're saying that too? Now mine is saying stop recording, so I think mine is saying it's recording.
Mine says it's recording as well.
Yeah.
it shows
so-
recording at the. Okay, I just wanted to make sure because mine's
Yeah.
showing like it hadn't started.
Yeah, oh
so.
no, that's great that you did that. Okay, go ahead,
Yeah,
Dan.
it looks like we're live to me. So hopefully there's a few of you out there listening.
Yeah, we're just talking to ourselves. That would not surprise me the way things are going. Okay, yeah, they can hear us. Okay, we're good. They're good.
Awesome. Well, Mark, thank you for the intro. Again, my name is Dan Godla. I'm the CEO of ThoroughCare. I'm going to talk about some of the changes to GO511 for 2024. And I did a webinar earlier this year, and I'm going to talk about some of the things that have changed since that webinar too. I'm going to give my own disclaimer as well that I'm not a lawyer, consult your own experts. There still are some gray areas, and I'm going to talk about two ways you can interpret a lot of things and you can come to your own conclusion. Keep in mind that anything we talk to today, CMS can issue updates at any time. And when we talk about rates, those can change too, just like we already heard. You can always look in the physician fee schedule. So that's my disclaimer. The final rule for 2024, we still see the rate about 71. I'm glad to hear that some of you have seen it in the $72 range. That's even better if that's true. But early this year, we were around 71.68. And anything, I'm going to talk about how this code is made up of a bunch of other codes. So if any of those other codes changes, it's possible that this rate could change too. But for your planning purposes, I think you're safe in the $71, $72 range for this code. There are some new programs that came out in 2024. And again, I did a whole hour on this. You can watch it on the YouTube page. But for those of you who haven't watched the earlier webinar, it's important to learn about new things that are included in the mix. There's some new programs one's called Community Health Integration, and this one's about focusing on SDOH, development, talking to patients about their history, desired outcomes, understanding things that can get in the way of managing their healthcare. And you probably have already managed SDOH, but this program allows you to get into more specific things like food insecurity, transportation issues, housing issues. So CHI is now a part of GO511, so it's important that you know that it exists because it is taken into consideration in some of these new programs. And I have a slide that kind of shows you how this all fits together, but CHI is definitely one of the new programs. And another one is called Principal Illness Navigation. This one is PIN, that's kind of the nickname, or PIN. And this is also a new bundle payment, and it's meant for managing one serious high-risk condition. So think cancer or dementia or something like that. It's a serious condition, and if that one condition isn't managed appropriately, this could affect other conditions from being managed. So CMS came out with this new program for fee-for-service groups. It's new in 2024. You may be doing a lot of this stuff in your chronic care management, but it's now a program that stands on its own, designed for those critical conditions. So the reason I'm mentioning these is that for rural health clinics, and I know most of you on the call are rural health clinics, Medicare created a general code. So instead of those specific codes like the ones I showed you, Medicare created one code and they call it general care management. And the way I like to think about this is a big pot of soup. And it's like CMS put a bunch of ingredients in the soup and there are different codes. This is last year's recipe. So you had things like CCM, behavioral health, PCM. You didn't have RPM and you didn't have those new programs because those just came out. And one thing about last year's recipe is you were only allowed to bill once per month. So I say limit one serving per person. Now this is the good news about 2024 is they added new ingredients to the mix. One of those programs is CIN or CHI. One is PIN, which I just talked about. And I think leading into this webinar, RPM is now in the mix. So remote patient monitoring is a part of general care management in 2024. So I know a lot of the RHCs we talked to and many of you on the call are very excited that CMS put RPM in the mix too. RTM is in the mix as well, remote therapeutic monitoring. There's still some limits on that program, which in our opinion, CMS needs to resolve, but we're incredibly thrilled that RPM is in the mix. And so the fact that you could do CCM and RPM and BHI and any of the other programs in 2024 is a great update for rural health clinics. And so the things to take away, GO501 can be billed multiple times in the same month for different care management services. And the line that CMS uses is as long as the resource costs associated with each of the services are separately accounted for. So you can't have a 20-minute phone call with the patient and say that was 20 minutes for RPM and 20 minutes for CCM. So you have to have your own 20 minutes for each. So if you were going to bill CCM and RPM, you need 40 minutes total. So 20 for CCM, 20 for RPM. And then you would get to bill 2 instances of GO501. RPM programs also have a code for number of readings per month. And for the fee-for-service side, they bill code 99454 if the patient has 16 readings a month. So it is still very uncertain if your patient gets 16 readings, whether you can count that as an instance of GO511. I see both sides of the argument, and CMS has not been clear about this. My instinct is that I probably wouldn't count it because general care management is typically a minutes-based code. But if someone were to make a case that why would they list the code in the ingredient list and not allow you to bill for it, I can't dispute that. So going back to my disclaimer, talk to your experts, determine what you're comfortable with. There's other programs in the pot like CHI and PIN and RTM. Those requirements are very restrictive in year one. So CHI and PIN are a great program. They have higher time requirements. They have physician involvement. And so I'm not entirely sure that I would recommend them at this point, but RPM and CCM and BHI, I think, are your best bang for your buck in terms of billing for general care management. So these are the codes that make up general care management. Again, all of these are in the list. 99490 is 20 minutes CCM time, 20 additional minutes, 99439, 99487, 99489. So back when we spoke earlier this year, there was a question, well, can we bill for the extra minute codes, right? CMS put them in the list, so they must want you to bill for them. Well, we finally got some clarity, and this happened since the last webinar. In February, CMS issued a knowledge booklet, and sometimes they do that. They're called MLN booklets. And there's this little tab at the bottom that says, this table doesn't include add-on pairs or codes that describe additional minutes. So this is the first time we've seen it in writing. And again, this is 1 month old here. It looks like CMS is not expecting you to count those extra minute codes. So again, the reason that it looks like they put them in the list to begin with is to get the average rate. So the rate, the $71, $72, is the average of all of these codes. So that's the part that is probably new to a lot of you. This is the first time that we've seen it in writing. So our advice is do not bill the extra. Do not consider 40, 60 minutes of CCM or extra minutes of RPM. However, you are totally fine with billing 20 minutes of RPM, 20 minutes of BHI, 20 minutes of CCM. So it's almost as if CMS wants you to do multiple code families as an instance of GO511. And then the other thing that I'll clarify too, and we're starting to see this more and more, is how you bill for it. And I think when we talked in January, we told you to just change the quantity. So if I got 2 instances of GO511, our recommendation was just bill quantity 2 for that. We've heard some stories about some MACs, and Mark, I don't know if you've heard this too, like that example in Palmetto. We have a group in South Carolina that Palmetto didn't like the changing of the quality. They wanted each GO501 on its own line item. So we're still investigating that to see if that's specific to this certain MAC, because we haven't heard it at other MACs across the country. And unfortunately, on the billing side, sometimes the MACs aren't always up to date on new changes. And so if you were to ever get a GO501 denied because you build it differently or build it with multiple quantities, it could possibly be that your MAC isn't aware this is a new program. And sometimes that happens with brand new programs. There's a lot of uncertainty on certain issues. So all in all, the changes for 2024 are very good. We encourage all of you to do them. And I think when you hear Levance and Sabrina talk about how the programs work, hopefully everyone on the call will want to start looking into these programs. All right, so that's it for my part. I'll stick around for the Q&A part in case anyone has any questions, but I'll turn it over to you guys.
Okay, thank you, Dan. That was excellent. Sounds like the big difference was in January or February, we were thinking, oh, we can fill up that one bucket of CCM and add to it. Now we can't fill up that one bucket. We have to go out and have other buckets to to bill for. So that makes a lot of sense to me. So okay, Levance and Sabrina, I'm going to turn the slides over to Levance and let him do the presentation, and I'll get out of your way.
Let's go see here. Can you guys see me yet?
There we go.
Yep.
You can see me. All right.
Um,
Great. Well, Mark, thank you for the introductions, and Dan, thank you for the update on everything there. Again, my name is Levance Northington, CEO of VitalSync. We are a care management firm that's focused on helping organizations, providers like yourselves, transition from the volume-based, fee-for-service-based care to a value-based delivery model. Can you guys still see my screen?
Yes.
You can. Okay, great. So a disclaimer, as Mark already talked about, you guys are eligible for 1 hour of CEU credits. We just have to be able to stay involved, stay engaged, and participate in 3 of the 4, not 4 of the 5, 3 of the 4 poll questions that we have. As we move forward, the agenda for the conversation today, kind of already had a little bit of introductions, but we'll talk about our core objectives. Advanced primary care, which is how we differentiate ourselves from others in the marketplace. Then we'll get specifically into remote patient monitoring. That's when Sabrina will come in and talk a little bit. We'll talk a little bit about our care management software, which is actually ThoroughCare. We are a partner of ThoroughCare, and most of our conversation will be based on the fact that we are a full service provider. But if in fact you want to, implement this yourself, then we would point you towards ThoroughCare and the ThoroughCare account manager that will work with you directly. So this conversation will be relevant for both sides of it. And then we'll get into clinical pharmacy. Clinical pharmacy, again, is a major part of what we do and is an extension of our remote patient monitoring. And then we'll get into Q&A. We've already talked a little bit about myself. I've been an operator for a couple of decades, been in healthcare, had a couple of healthcare startups, and that's led me here to care management. Sabrina has an extensive background in care management through her work at, with ACOs, particularly in billing and in care management itself, but she'll talk a little bit more about that. So let's get into our objectives. In every engagement that we have, our goal really is that of the triple aim of the industry, and that's to improve clinical outcomes, to implement population health management strategies, and to reduce the cost per patient per capita. And as an offspring of that, that's we reduce staff administrative burden, improve quality measures, and then at the end of the day, generate additional revenue for each one of you guys. So let's talk about advanced primary care, and this is really where we try to separate ourselves from the rest of the market. Traditionally, primary care is defined and focused on the physician group. With us, we look at primary care differently, kind of looking at it like the food pyramid, where the physician group is just the foundational element of primary care, and we overlay that with care managers who work on, chronic care management, remote patient health, behavioral health integration, then community health integration, where we have the community health workers, a care navigator. We overlay that with a population health director, which is our director of clinical pharmacy. That's really an informatics position, trying to identify via data at-risk patients. So that if someone like Levance has, kidney stones 3 times a year, we can identify that and have our care manager and dietitian work on those things. And then lastly, we overlay that with a clinical pharmacist. And as you can see, that's at the top of our pyramid. And we have that there because we really think clinical pharmacy is the silver bullet to achieving the triple aim in our industry. There's, with the population of doctors going down, and having so many clinical pharmacists available and clinically able to diagnose and treat these diseases, we think clinical pharmacy is really important. And so we power all of these things, and CMS, fortunately, pays for all of it. As Dan talked about, I won't get into the rates. CMS reimburses for everything that we provide. Remote patient monitoring, chronic care management, behavioral health integration. We do annual wellness visits, principal care management, a number of different things, as you can see here. And as Dan talked about, community health and integration and RTM are new to the mix. And we leverage all of these things in providing our services here. So why is CMS paying for this? You guys understand that 2/3 of all Medicare patients are on chronic diseases, and we're really focusing on chronic diseases because 99% of their expenses are going to chronic diseases. So with our patient-centered services, our patient-centered offering, not only does the patient win and benefit and get improved clinical outcomes because of the additional quality of care, but the doctors also, the physician groups and you guys also win. Not only are your patients having improved clinical outcomes, but you can earn upwards of $500 a year just from 20 minutes of remote patient monitoring, even when outsourcing. And again, that's with no cost out of pocket or no monthly ongoing basis. VitalSync pays for everything, all the devices up front, and CMS pays for all the recurring bills. So let's get into remote patient monitoring. I think we may have a poll question here.
We do. I'll go ahead and make it live. So the poll is now open.
Yep, there we go. What are your thoughts on remote patient monitoring? You're already doing it? Is it something you plan to do in-house, or you'd like to learn more about outsourcing, or not sure yet? Give you a couple of seconds.
We've got a lot of answers rolling in. I'm gonna let the poll run for about another 20 seconds or so that everyone can get a chance.
Yeah, Trent. Yeah, give people a chance to answer it, because we'd hate for them to miss out on a chance to get the CPE if they miss one of these. So,
Absolutely.
But yeah, Levin, I think that are y'all seeing y'all's business grow? Just because, I mean, those numbers that I was seeing, I mean, 25% of the people going on remote monitoring, that's really outstanding, amazing growth.
Yeah, there's definitely a growth happening. There's a lot more interest in willingness to understand throughout the entire industry. A lot of the industry have, obviously have heard about chronic care management and remote patient monitoring, but it's too resource, I guess, intensive from a personnel perspective, from a finance perspective, and a technology perspective. And so they didn't want to take that on. But now that they're hearing about outsourcing, and in 2021, CMS allowing it to be outsourced, there's been a lot more activity on our behalf. And so, yeah, it's exciting times.
Yeah, one thing I noticed at the NARHC meeting in San Antonio there was probably 5 remote monitoring vendors there. So the next one is in Grand Rapids. So you probably ought to talk to Tasha about exhibiting, because that's where a lot of our friends are there, and that's a great place to be. So, okay, I think we've given enough time, Trent. What's the poll results?
So we're here at about 2 minutes. It's leveled out 76% reporting, and of those reporting, about 13% are already doing RPM. 19% plan on doing RPM in-house. 11% would like to learn more about outsourcing RPM, and then 57%, the vast majority, are not sure yet.
Okay, great. I am going to hand it over to Sabrina, and she's going to talk a little bit more about, actually what remote patient monitoring is as it pertains to us and how we implement it. Sabrina?
Thank you. And if you guys have any questions, Darren, please put it in the chat, and we'll have a section at the end to answer any questions that you have. So for those of you who are not familiar with remote patient monitoring, we're able to do pulse oximetry, blood pressure scale all from home. They're devices that are synced up, kind of like your cell phone with a SIM card, and the readings come directly in. So you do not have to wait until the next patient appointment to get their readings for their last 2 weeks worth of blood pressure. Those come in real time. These are monitored 24 hours a day, 7 days a week. So it's very nice if a patient does have an elevated blood pressure, for example, and you have changed their medication, we're able to see that, notify you, so they don't have to wait 30, 60, or 90 days until they come back into another office visit. We are what we call a white glove service. So full service, we check to make sure the patient's eligible based on their insurance and their diagnosis, as well as helping get them started, enrolled, set up with the devices whenever they have those. Again, there's no upfront cost in getting started with the RPM program. Those devices are provided by us, and then there is the reimbursement that comes in monthly from Medicare. Customize alerts, and we'll show you this a little bit further down when we go over what our system looks like. But the nice thing is we can customize alerts as a whole with your patients or on an individual level. So if you have someone whose blood pressure tends to run a little bit low, you may not want them getting calls every single time that blood pressure is low. So we can customize that and know what's unusual for that patient, and then reach out to them anytime that is alerted to us. And this is just a quick look at all of the devices that we currently have. I personally use the blood pressure cuff as well as the scale. So I'll kind of go off the slide here. In the last year, by using the scale, I personally have lost 72 pounds. And for 2 years, I've had a blood pressure cuff. When I first started, I had high blood pressure, on medication, and now I'm taking medication. So it's been very handy to me to be able to have these devices personally in my house, know what's going on. It makes me more aware of my health, and I feel like that happens with the patients as well with each one of those. Okay, so as we know, many patients have hypertension, obesity, diabetes. I just spoke on 2 of those. And so the majority of patients do qualify to have these devices. What we have found is that by having the devices in the home for patients like congestive heart failure who use a scale, we're monitoring if their weight goes up, we're able to avoid some of those ER visits. Same things with the hypertension. If we can catch that reading high as soon as it comes in. You know, sometimes patients will panic and they will go to the ER if they see it. Sometimes we're talking to them and having them uncross their legs, retake the reading, ask what they ate, and calm them down. There's other times when their blood pressure is elevated and possibly at stroke level. So we are able to catch those, notify the practice. If it's something going on that the patient needs to go to the ER, of course they're going right away. But the majority of the time when they have an elevated blood pressure or something abnormal that comes in, we're able to speak to them, get in touch with their provider, and do something at home and avoid those costly ER visits and hospital admits. Right, so we continue to have engagement as we go throughout this program. I'll kind of go through the 4 steps that we do quickly, and then we'll have a slide over each one. So first is eligibility. Then we're going to do the patient enrollment and onboarding, make sure they know how to use the device, when to use the device, how many times a day to use it. We want to make sure that they're adherent to everything. If we'd like them to take their blood pressure reading twice a day, we want to make sure that they're doing twice a day. If you have them on a weight loss program, we want to stick to them and make sure that they're following the guidelines and the nutritional items that you've listed out. And then finally, the billing and reimbursement. And we definitely want to make sure that we are all getting reimbursed for the hard work that we're doing, and increasing these patient health outcomes. So patient verification and eligibility. So we're mainly talking about Medicare today. There is a few other payers that do pay for these, actually quite a few. But when we look at Medicare, we want to make sure that the patient, one, has Medicare, we have the correct information in it, and that they have a diagnosis to go hand in hand with the device that they're getting. So for example, if they're getting a scale, we want to make sure that they're either have a diagnosis of obesity or congestive heart failure, whatever we know that is going to make you justified to the insurance to get you that reimbursement. As well as there is commercial payers that pay as well. We'll do the same thing for those. For those of you here who are interested in enrolling your commercial payers, part of an IPA, will take care of making sure those patients are qualified. So the enrollment and onboarding. So I'm actually just kind of going to go off the slide and tell you two different ways that we do this. So with the devices, we can ship the devices directly to the patients. Whenever they receive the device, we get a notification, a shipping notification to make sure that they got it. We call the patient. We make sure they know how to use the device. We have them take the first reading with us on the phone, which again is just plugging it up, putting that cuff on and hitting power or stepping onto the scale. There's no app to download. You don't have to connect to the Wi-Fi. It all has SIM cards. So that's one way that we onboard patients to get them going. The second way is if you give them a device in the practice, and some providers do prefer to hand them the blood pressure cuff when they're there in the office. If you do that, of course, we're notified when the patient gets the device and takes the first reading. We still do the same thing. We call the patient, we educate them on why it's good to take their reading once a day, twice a day, and we will continue to follow up with them until they are in the habit of taking the readings the number of times a day that's been ordered. So the patient adherence, this is really important. How many of you guys, I'm sure there is some MAs or some providers on here, do something like change your patient's medication. You tell them to do a no sodium diet, and then they come back 3 months later for a medication refill and tell you their blood pressure has been high every single day. They didn't pick up their medicine, and they're still eating, bacon in the morning and covering everything with salt whenever they make their dinner. So we're going to be on the phone with the patients. We're going to make sure that they're adhering to taking the readings. We're going to make sure if the readings are elevated or abnormal, that we're finding out why and getting to the bottom of it, and then notifying you. So you do not have to wait their next 30, 60, or 90-day appointment, or for those who only come in once a year for their annual wellness visit. We want to make sure that you're getting notified of that in between the visits, which is going to cut down on those ER visits and hospitalizations. Billing and reimbursement. So this is always the important one. So if you happen to get a denial from insurance, no big deal. Send us over an ELB. We'll be glad to assist you with it. I personally have about 22 plus years actively in billing prior to doing this. And I still keep my CPT certification up to date and attend all of my CEs. So generally, I'm able to assist you with being able to fix those claims, find out if we need to add a modifier on the number of units, diagnosis pointers in the wrong place, or if the insurance just doesn't cover it. If for some reason I can't help you figure out what's going on with billing, then we will reach out to the next step and we will help get that resolved. When it comes to sending the claims monthly, you get a detailed report that's going to tell you patient's name, date of birth, date of service. The CPT, of course, is the same for all of them, the GO511, what diagnosis code, and if there is multiple units, how many units to bill on there. So quality metrics. So I'm sure some of you guys may be in an ACO. If you're part of an ACO, of course, you're doing the GPRO reporting. Everybody has heard of MIPS and MACRA and HEDIAS and your star ratings. This absolutely does improve all of those. One, if you're getting patients aligned to you, like for an ACO, this is a great way to have additional patients aligned and patients who are compliant. Patients who are taking, doing RPM and taking readings on a monthly basis has claims that are going in on a monthly basis. Therefore, they're associated with you and they can help with your alignment for the next year. When it comes to compliance with the patients, we have great compliance and keeping those patients out of ERs, hospitals, driving down that spend, which is also going to increase your star ratings whenever it comes to Medicare. With your commercial payers. When it comes to Medicare, with your MIPS and MACRA, we're also gathering additional information when we're on the phone with patients. We are finding out if they have had their flu vaccine, if they've had their pneumonia vaccine. So we're being able to hit some of those metrics that you may not be able to hit whenever they're in office.
I'm sorry, Sabrina, if we can't hear you as well, you kind of go in and out a little bit on the speaker, so.
That
Sorry.
is better.
Is it almost time to do another poll question too? Because I know we're running late on time, and we'll make sure we get all those in. So,
It's
Trent, why don't you go
actually
ahead and do one just so we get it in?
Sure.
Yeah,
I
I
believe
think
we're
it's,
about at time for the second one. I can launch it.
Yeah, go ahead.
so after hearing everything that we have, why do you have interest in remote patient monitoring? What's the driving motivation here?
Improved clinical outcomes. That
Yes.
Sabrina, that is amazing what you've done. I mean, congratulations. That is quite an accomplishment. I have to give you credit for doing that. That is amazing. And it's very hard. I know I've been trying myself. It's so hard.
All right. I think we're good on that. We can close the poll. We got about 74% of the votes in. And
Yep.
80%. Yep.
I'll go ahead and close it. And then what we're seeing right now, and I think I can show this, yep, is 80% looking to improve clinical outcomes, 19% for generating revenue, and then 1% for need additional staff.
Perfect. Perfect. All right, we'll get back to it. Go ahead, Sabrina.
And of course, everything we do is compliant. Our system has everything safely done, make sure that that's all taken care of. It's cloud-based. We also integrate with the EHRs. We have a list down at the bottom of some of the EHR systems that we have integrated with. Integration is not necessary. Of my clinics that I work with now, it's about 10% that's actually integrated. So do not have to have integration if you're working with the EHR. If that is difficult with that, it's very easy. You just upload the information into your EHR system instead of it automatically.
Yeah. Okay. We'll move it on to the software. And again, this is actually this is ThoroughCare software that we're showing. We are a certified partner of ThoroughCare and leverage their technology here. So, Sabrina.
Okay, so this is just kind of showing you a snapshot, and again, you can always get a demo of the system. I'm going to reach out to us afterwards, but this just kind of shows you a snapshot of what our staff sees or what you can always log in and see. And this is whenever we're setting up their care plan and some of the goals. Some of those goals may be, to reduce the sodium, to walk 30 minutes a day, whatever it may be. We're able to go over those questions with the patients to see what realistically they can do. And then we're able to track those and see the different outcomes that happen.
Right.
And this is just a screenshot of our care plan dashboard. So all of the minutes, these 20 minutes that we talk about, that CMS puts them in increments for your GL511, all of our minutes are tracked. So not only are they tracked on here, all of the telephone calls are also backed up to a cloud-based system. So those recordings are there in case there ever was a request for documentation or for records. It's all in here. It will not let the patient be billable. This is something I absolutely love. If we are setting like this one at 18 minutes and 39 seconds, you are not going to see a claim for the patient. We have to reach those thresholds. And ThoroughCare has done a really good job at putting things in place. No one can go in and just override that and make it billable. So the documentation's in there. You have the information to back it up prior to the claim going out. So this is just another just a screenshot of what our CCM staff does. So CCM and RPM goes hand in hand. I know we're specifying on the RPM today, but most of those patients that are in RPM do qualify to be in CCM, and it's a great way to track some of those other things that they may have going on or additional chronic conditions. On this slide, what we're looking at is the parameters. So earlier I said we can set notifications. We can set a global notification, and that's kind of for your practice. If it goes above a certain range, we're going to call the patient right then and there to make sure it's okay. We can also set those individual ones. So this is an example of, let's say, Miss Smith. We can move Miss Smith's parameters up and down. So we are immediately notified if she goes outside of that range. And this is just a snapshot of our analytics. And again, I'm a hands-on person, so if any of you guys want a demo or you want to take a look at it, please let us know, us or ThoroughCare, so they can get you in and you can see this real time. But this is just some of the things that we can track. We can take a look at how RPM's doing, PHI, CCM, all of those categories that are covered under the GO511. We can take a quick look and just see how those patients are doing and how our staff's performing per month.
All right.
And then this one is really good, I think, as far as an overall. So if you take a population of, say, 50 patients that's going to have, blood pressure cuffs, and we're going to give those to the patients, we kind of want to see, is this making a big difference on a big scale, or is it really only affecting 1 or 2 patients? So we're able to take a look at some of the different analytics in the system and see, is those patients really improving, or are they just taking readings? What's going on with the overall outcomes with those patients? This is really nice to have. Same thing here. This is going to be on your conditions, so we can take a look and see what is your population, doing the most. Do they have more hypertension? Do they have more diabetes? What education or what other programs can be put in place to help the biggest portion of your population? And then we're able to track the outcomes over a period of time as well. This is also really helpful at getting your star ratings, your HEDIS ratings up. Is being able to target those patients with big diseases. I know hypertension's big on this one, but everybody knows that chronic disease management is really hard to do. Really take a look and see just how many patients of those with chronic disease also has other things going on, and how can we help them. All right, and then the last thing, this is just another quick look at the analytics. Again, we can look at how many patients have devices, how many actually generated claims. Same thing with PHI, CCM. This is just a quick shot and like a graph to let us know how we're trending and how we're tracking and what we need to do to make changes to get those numbers up.
All right, I think we have another poll coming up.
All right.
I'll go ahead and get it launched. So, does your EHR system track patient health outcomes?
Interesting results. Just about a 50-50 split, it looks like we're coming up with. Good. Okay, we can close it out about now.
Okay. Let's see, we're getting a couple more in. We'll give it about 5 seconds. 2, 1, and we will close it. Share it. It is almost exactly a 50 split.
Nice. Okay, good. So there would be a lot of value to this, to the ThoroughCare platform here.
Can I add just one thing on that? So for the outcomes, for those of you who are in an ACO, and we should have put a poll question in for that. So those of you who are in any type of an ACO or a risk-based model, you have a claims lag in getting your information in and then taking a look at your data analytics to find out which patients you need to target. So this is real time. This information inside the system, as soon as we enter in a patient and their chronic disease and we start doing updates, this is real time. So this is even before the claims are submitted. So you're able to target those patients earlier, make a difference earlier, and not have to wait on that claims data to come in to see which one of those set of patients you really need to work.
Okay, great. All right, I guess I will take over from here. We discussed earlier at the top of our pyramid is clinical pharmacists, and we truly believe that clinical pharmacists are the healthcare silver bullet. As I mentioned, with all the shortages with physicians around the country, we have over 300,000 clinical pharmacists around the country that are, medically able to, do medication management, to do disease state evaluation. Particularly, we do 16 disease state evaluations and management, and to counsel both the doctors and the patients as well. And so we're leveraging clinical pharmacists in delivering our chronic care management and remote patient monitoring, just to give a higher quality of healthcare. One of the things that we do that we lead in that's an extension to our remote patient monitoring at CCM is we do a medication checkup service, and every patient that has chronic disease should have a medication checkup service. It's basically the core elements. We do a medication review, understanding everything. When we're on the phone, we will find out have them bring with them every medication that they have, whether it's prescribed, non-prescribed, over-the-counter, herbal and dietary supplements. Now with people, 50 and up are using a lot of, herbal and dietary supplements. They have no idea of the counterindication between those, the interactions between those negative interactions. So we'll understand that and put together a laundry list of all of their medications. And then from there, we can start asking questions and figure out a game plan moving forward. We want to know if they're taking unnecessary medications. Are there medications that should be subscribed? Is the medication effective? Are they having side effects? Are they just not taking the medication appropriately? And then from there, along with the patient and maybe the patient's family, we put together an action plan, because if you're taking 10 medications, maybe we want to get down to, 5 medications. What's the action plan to move forward? And then we monitor on that on a monthly basis. And we do that as a part of our RPM and CCM. Again, even if you do, or if you are running this service yourselves and you don't have a clinical pharmacy in-house, we can provide this service for you as well. So every patient really should have this. And non-adherence to medication is one of the biggest cost drivers to driving up the cost of healthcare in our industry. And so when we talk about the triple aim, and one of those being reducing the cost per capita, non-adherence is a big player here. And so here's some statistics that I think are very eye-opening. Of 100 prescriptions filled, written, less than 70% are actually filled, and less than 30% are actually taken properly. When you talk about the economic impact on that, you look at $300 billion a year are associated to non-adherence when it comes to hospital expenditures, $130 billion for adverse drug reactions, and $6 billion for DDI, drug-to-drug interactions. A lot of this can be cured and removed just with the medication checkup services that we provide. Beyond the medication checkup services, again, how we introduce clinical pharmacy into our practice and into yours after medication service, we do a collaborative agreement. And that really gets into helping to evaluate and manage diseases. And again, we evaluate, manage 16 different disease states. So that's a collaborative agreement. And then if things are working good and we're trusted, we actually can put a pharmacist in the clinic to be a part of the day-to-day operations, where they're actually taking those collaborative agreement, those patients that they're managing on an annual basis, on a monthly basis, meet with them in the clinic, or become an extension to what the doctor is doing. If the doctor is prescribing a certain medication, they would the visit with, okay, now our physician will come in and talk to you about those medications. They'll spend 5 minutes talking to them. This has a profound impact on, those star ratings, as we talked about. And so is there any evidence here for, integrating clinical pharmacy? And the answer is yes. There's been a ton of evidence, but the most profound one was the Surgeon General did a study outlining how clinical pharmacy has been integrated into the healthcare system and how it's impacted our triple aim. Improved outcomes. There's over 55 different evidence-based outcomes that were improved through this study. Improved population health. When there is no clinical pharmacist involved, healthcare literacy is extremely low. And when we talk about healthcare literacy, we're talking about excessive and at times inappropriate use of therapeutics. Non-adherence is very low. And then there's very poor communication. When you introduce a clinical pharmacist, all of those things are removed. Communication is increased, adherence is increased, and the excessive or inappropriate use of therapeutics goes away as well. So there's a great deal of evidence behind why we want to implement clinical pharmacy and why it's so important to how we integrate into the industry. And it's our goal to revolutionize healthcare through implementing clinical pharmacy into our platform. And so I think that's about it for what we have to say. And we can go into questions for it right now. So I think we have another poll question. Do we have another poll?
We
Yeah,
do
one
have
more.
one more. Let's go ahead and get that one launched out before we jump into Q&A, just to give people a chance to make sure they get their 3 out of 4. So this is your last chance to answer a poll question. So we'll give people a little bit of time to get their answer in. Looks like we got answers coming in pretty quick.
Okay.
Yeah, our timing is pretty good. We said it's a 1-hour webinar in total, and we're at 1:55 Eastern time. So we have about 5 minutes of questions. So we did really well on timing.
All right.
How's our answers looking, Trent?
Looking pretty good. Let's see. We've got 67% reporting after 45 seconds. I'll give just probably another 10 seconds just to see if anyone else needs to get it
We
in.
had a few people drop off. It's getting later in the hour, that usually happens.
Close it out. All right. So we got 1 minute. So I'm gonna close it out. I'll share the responses just so everyone can see. So we got 19% already integrated. 33% would like to learn more about clinical pharmacy integration, and then 47% have no interest.
Okay. Yeah, that's surprising that no interest, because I think that would be a really amazing thing. I know with my medications, I'm very good at managing my medications and taking them, but there's so few patients that really do that, and it makes a big difference in your life. So let's go ahead and we got some questions here. So let's go ahead and ask those. First question from Keisha is, do the devices have to be able to report in real time? And then the next part, I guess the second part of that question is, can the patient use a manual device and self-report to the office for the office to bill RPM? So does it have to be real time, or can they just do it manually and then report?
For actual RPM, so for remote patient monitoring, it must be able to connect and digitally upload real-time information. So it does need to be a device that connects in and brings that information in.
So it does have to be, okay, yeah. You cut out a little bit there. I think we got a couple of people saying that you're cutting out there. So, but it has to be real time in order for it to count. So, okay. Let me see here. Let me go down. Okay, what percentage of patients actually achieve the 16 readings per month?
So I can tell you we've been doing RPM for right at 3 years with multiple clinics, different areas. On average, we have about 85% of the patients across the board. Some practices are a little higher, some practices are a little lower, but about 85% of those do reach the reading threshold per month.
That's great. I'm surprised the number's that high. So they're more compliant than I thought they would be. That's great. Okay, let me see here. This is a great question, especially for this audience here. Have you done any RPM in rural areas where the internet is limited?
Yes, so we have, and in case you can't tell by my accent, I'm in Tennessee. So there's a lot of rural areas here.
Where are you in Tennessee?
I'm about 45 minutes south of Nashville, but we have a ton of rural areas here, as well as we do people all across the country. So they don't actually have to have internet access to use these devices. As long as they can get cell phone reception service in their area, then the device will work. So it runs off of a SIM card, much like a cell phone, so it will work. Occasionally, we'll have a patient that's in an extremely rural area and has no cell phone coverage, so they don't have to use their phone, but it uses a SIM card like a cell phone. So no, they do not have to have internet access.
Oh, okay, wonderful. Let me see here. Okay, Dee's asking.
Mark is in Chattanooga.
Go ahead. What's that?
Yeah, Sabrina, so Mark's in Chattanooga. You guys are close.
Oh, are you in Chattanooga? Oh, no, I'm in Murfreesboro. So.
Oh, okay, all right. I went to school in Murfreesboro. Go MTSU. Right. Okay, perfect.
MTSU. Okay, I'm down the street.
Yeah, okay, perfect. Okay, good. Okay, so let's see. Dee's asking, what is the cost for us to bring on RPM? So I guess you guys would know. You guys do that. So
from a cost perspective, if it's outsourced, there's zero cost up front for the devices. We incur that cost, and then on an ongoing basis, there's zero cost. CMS will reimburse you for all of our services, and we bill after after you're reimbursed. And so, for instance, if Levance does not get reimbursed and I don't beat my 16 readings, we won't bill you for it, because that is, that's our fault for not making sure that that patient adheres to, the program itself. So the cost is zero for you if we are doing it. If you're doing it yourself, the devices can range, anywhere from $75 to $150, and then you're talking about, the personnel necessary to manage the patients on a monthly basis and making sure that they get those 16 readings. 16 readings are very, very important. It's very labor intensive, which is why our industry was born in 2021, because that's our core competency. That's what we do, and we're fairly effective in making sure that the patients adhere.
Okay, that makes a lot of sense. Okay, and then the next question is, what is the reimbursement for clinical pharmacy management? Is it the same $71, $72 per month?
Yep, it's the same G0511, and at times we will bill incident 2 as well, 99211 through 99215. So we'll bill based on what we're doing, but generally speaking, it's the G09511, and it's an extension of CCM and RPM.
Okay. This is probably going to be an off-the-wall question, but does what is it, the 340B program, does that play into the clinical pharmacist at all, or is that just or no?
No, no.
Okay. I thought that was just an off-the-wall question. Okay, let's go. See, Rhonda has, are these codes only billable from an RHC? The G0511, I know for sure is that's the code that you use for RHC, but I guess there's other codes as well, and Sabrina knows billing better than I do. But if we weren't talking to a rural health clinic, we're talking just a normal physician practice, they have those normal CPT codes that they can use, and that's that whole pot that Dan showed that showed all those CPT codes. That's what they can use, correct?
Yes, that's correct.
Okay, all right, that's good. Okay. Okay, we'll keep on going here. Looks like the questions are starting to fill up. Oh my, okay, Tanya's got a long question here. Can 2 units of G0511 be billed if the patient received 20 minutes of CCM and 60 minutes of complex CCM in a month? If 80 minutes were spent on the patient in the month, my understanding was no, since they're in the same care management subgroup of CCM. My answer will be yes. You're correct. They can't do it, but Dan, you know better than I do. What's the right answer?
Yeah, I would agree with you that you can't do that. However, why don't you do PCM with that other condition? Because you can do 20 minutes of CCM and 30 minutes of PCM. So you don't need to even get to 60 to do that scenario. So that's the way I would do it. And you are not using extra minute codes in that example.
Okay. Next question. What is the difference between PCM and PIN?
Okay, I'll stay on that one.
Okay. All right.
So I think PCM is more designed for a specialist. So let's say you're a cardiologist and you only focus on heart conditions. I think when that program was initially designed, they would be okay with that doctor doing your heart-related conditions, but then you also have diabetes and hypertension and someone else is managing those. So I think that's where PCM is typically, if you focus on one specific condition, you can do that. PIN is where your patient may have many conditions, but one condition not being managed correctly can affect them from having overall improvement in their health. So I mentioned like dementia, for example, where if you don't get that program managed and you don't really understand all the issues related with that program, you don't have a care plan for that, it's going to be very hard to do anything. You could tell your patient to take their blood pressure, but they're not going to do it because you really have to get to the root cause of that problem. So there are I would say there's a lot of similarities between the programs. Sabrina, I'm interested in your thoughts as well, but that's kind of how I would distinguish the two programs.
No, I think you explained it well.
Yeah, one thing I guess an easy way to determine what CCM and what PCM is. CCM, chronic care management, you have to have 2 chronic conditions, if I remember correctly, while principal care management, you only have to have 1. And my understanding is, again, y'all are the experts in this area, is, you can correct me if I'm wrong, is you can have somebody doing, maybe you have your internal medicine doctor doing chronic care management, and they're managing, diabetes and hypertension. And I also have my cardiologist, who Dr. Warren is doing my my PCM as well. So you can have both of those. Is that correct? So okay, perfect. Okay.
Yep.
Okay, very good. So okay, since we bill on a UBO4 and Palmetto GBA only recognizes revenue codes. Well, everybody, I mean, that's everybody there. Everybody only recognizes revenue codes for Medicare. Will they pay us a CPT code, specifically GO511? And I guess yes, the answer is yes. That's what they're supposed to pay. Yeah, now what's going to happen is you're not going to receive. Remember, we say you get 7290 or 7164 or whatever the number is today that you're supposed to get. You're only going to get 80% of that from Medicare. So your payment is going to be around $56.80 or so, and then you're going to collect 20% from the patient up to that $72.90 or whatever that number is today. So just keep that in mind. There is a limit on it, which is unusual. It's not the way it normally is. Okay, what will be the cost of a patient without insurance?
I can probably speak to this and give you an example. So we have some providers that use the scales for weight loss for cash pay patients, as opposed to billing it through insurance for congestive heart failure or something, and they just set a rate. So for those patients that they're going to do an office visit with and use the scales, it's like $75 a month. If they're only going to use the scales and they're not going to come in for a visit or do a telehealth visit, they'll lower that down to say $39 per month. So that's completely up to the practice. I would, if you're going to set it up as cash pay, I would definitely set it up as a monitoring program, not necessarily remote patient monitoring. If you want to do the amount less than what you're billing insurance for. So if you want to set it up as a blood pressure educational monitoring system and do a flat $50, it cannot be called the same thing as what you're billing insurance for if you're going to change the rate. Otherwise, you have to bill them what you're billing Medicare.
Okay, that's brilliant. Okay, very good, very good. Okay, next question from Keisha is, why can't we bill RPM for CGMs, which I don't know what a CGM is, but that's Keisha's question.
She may mean CCM.
Or continuous glucose monitor, maybe like a Dexcom or a Libre, right? I mean, I could take it. You can do it. That could be one of your devices. The challenge and why we don't see it a lot, and Lance, maybe you see the same thing too, is that you have to supply the device to the patient, and they're pretty darn expensive. So a CGM, you're looking at the hundreds of dollars plus, and then you have to change that applicator every so often, but you have no problem getting 16 days of readings because it sends you a reading every 5 minutes. So that's just my thoughts. Lamance, what do you think?
Yep, I concur. Yep, the cost.
Okay, Mary Humphreys. Hi, Mary. What if the patient has home health? Can they still do CCM as well?
They can. I love home health patients. So CCM and RPM both. You have somebody that's there, even if they have a full-time nurse that may come, 8 hours a day and do dishwashing and things like that. So those are the best ones because you really get the good information from the caregiver. So we don't have to speak directly to the patient on CCM. We can speak to the caregiver, and they are very good about relaying information and getting things in front of the doctor before it takes, goes too far. So they absolutely can be billed on home health.
That makes sense. Okay, and then Tammy's asked that she missed the first slide. How do we obtain credit for CRHCP? Number one, you have to watch it live, which you're doing, so you've got that down, Tammy. And number two is you have to answer 3 of those 4 poll questions that Trent provided for you. If you've done that, email Trent, and he will get you out your certificate. The next time we do one of these, we're going to have a little place to mark on there. So if you are if you need credit, then you can mark ahead of time, and then Trent will have a listing and he'll send out all the certificates at one time. But for right now, we're learning how to do this, but that's going to be, that's the way that you can get credit.
Mark, real quick, I'll just jump in. What my plan is, I'm going to go through, as soon as we get the insights report from GoToWebinar, I'm just going to go through and see everyone who's eligible, and I'm just going to send a certificate out to everyone who qualifies. So anyone who answered the 3 of the 4 questions should be getting a certificate. If after a few days go by, if you think you should be eligible for one, you haven't gotten one, then send me an email and we'll see if we can work out what the hang up is.
Okay.
But I'm just going to plan to send one out to everyone.
Okay, that's like a very easy plan. Okay, Trent, very good. Let's see here. Do we get reimbursement, or VitalSync gets the reimbursement? So sounds like from what you said, Lance, was that they would get the reimbursement and then they pay you after you get the money. So
that is correct.
Now, is it a flat fee that you guys charge, or is it a percentage, or how does your charge structure work?
It's a flat fee.
It's a flat fee. So, okay. Okay. Okay, I'm just joining with the 0 upfront cost with you doing it. What's the range of reimbursement for, let's see here. Wait a minute, I lost it. Where did it go?
I think they're asking what the range of reimbursement is. If you are an RHC or any federally qualified, center, then it's the 7290. G0511 is 7290, and that encompasses a number of the services that we've been talking about.
Yeah.
If you are not federally qualified, then there's a range of costs of reimbursements that you would receive, and I can give you that offline.
Okay. And the next question then is Becky's asking, can she only bill one GO511 per month once she becomes a rural health clinic? The answer to that is, thankfully, no. You can bill more than one. Now that changed in 2024, so you do have to be in each the different buckets. You can't just fill up all the CCM, and bill 4 or 5 times for that particular CCM. But if you do remote monitoring and you do CCM, that's 2 different buckets. That's 2 different visits, and so each one of those buckets you fill up, that's an additional visits. What's the most visits you've ever seen paid in 1 month, Dan? Have you or Sabrina? Do y'all know?
I don't have that stat because it's so new. I'm almost confident we've seen a 3, but I don't know that I've seen anyone. But again, it's so new.
Yeah, I've seen a 2. Somebody sent me an EOB the other day, and they paid for 2 at least. So I've seen that.
So it looks like Becky's used to bill in the 3 codes. So for the 16 readings plus your 20 minutes plus your add-on code, Becky, I would strongly suggest you guys looking into doing CCM, because if not, you may lose out a little bit where you've been getting reimbursed for 3 codes and you may have been billing your 458 times 2 times 3, depending on how many minutes you add on. So I would consider adding on CCM, so you can get your $72 from RPM, your $72 from CCM, and then your total reimbursement should be actually a little bit more than what you were getting for billing those 3 codes. If you were billing those 3 codes and you just switch over to billing the GO511, you're probably going to lose just a tad of revenue per month if you were billing multiple of the 458. So definitely look at adding on, putting them in the CCM or one of the other categories as well when you're talking to them.
Okay, perfect. Okay. Does VitalSync do billing, or do providers office bill? If so, do we bill based upon your instructions? Okay, Sabrina, that's you, huh?
Yeah, the provider's office bill. So we give you a list. It's actually in ThoroughCare. We can send it to you. You can log in and get it, and it gives you all the information you need to bill, data service, your diagnosis codes, everything on there, and then you can send those out. If you're integrated, it's just a click of a button and you submit the claims.
Okay. Next question. Are pharmacists able to receive reimbursement in the RHC when they do medication management with patients?
Indirectly.
What's that?
Indirectly. We don't get it directly. We bill, it's under the Part B. And so as an extension of or under the advisement of the doctor, we can bill. And just like we bill for CCM and RPM, because we're billing under, as a part of our RPM program.
Okay, so that piece of it would not be an RHC benefit. You're billing it, you say that, are you billing on the 1500? It's when you say you're billing at the Part B, that's confusing
We're
to.
billing under 0511
Okay, so
for
okay, so
the pharmacy services. So it's just like having a care manager, but instead of a care manager, we're using a pharmacist to provide additional services in our RPM and CCM program.
okay, now I understand. Okay, perfect. That's what I thought. That's what I thought was going to happen, and then you started saying Part B 1500, Part B, and when the problem is when you
They're
deal with
billing
Rural
A.
Clinic all the time is it a part? Rural Health Clinic is actually paid from the Medicare Part B trust fund, but it's paid for through a Medicare
Right.
Part A UBO 4 form, and you just like it just drives everybody crazy on what's really happening. So okay, okay. So we'll do a few more here. Hey, we're right on 15 here. Let me see here. Oh, okay, here we go. Let's see, do we do CCM and RPM? Do we bill GO 511 and one line? And Sabrina, I'm just gonna let you take that one.
Yeah, bill it on 2 separate lines. So I have found, I don't know if anybody's Noridian, but with Noridian, sometimes, and that's with Medicare, if you're in their areas, sometimes Medicare will kick back the second line. For those, if they resubmit with a 25 modifier, then it'll go through. But you do want to bill it on 2 separate lines. If you're doing 3 different services, you want to bill it on 3 separate lines and make sure that your diagnosis pointer is pointing to the correct diagnosis for the programs. So if you're doing CCM on the first line, have that 2 diagnosis, RPM on the second line to the 1 diagnosis that correlates with, and so on.
Okay, and then the next question Sheila has, which this is a really good question. Do you have an affiliate link where I can refer providers to you? Because I would like that too. Do you have an affiliate link so we can send people? Yeah, we want to be an affiliate too. So do you have anything like that for people, for Sheila?
Yeah, we can talk.
Maybe these social influencers. Maybe I'll get me a TikTok and do dances and send people your way. How about that?
I can see that, Mark. I can see you doing TikToks. That'd be good. We'll take it. Yes, we can talk about that for sure.
Okay, yeah, you can. All right, Sheila, you get a hold of them. If you want to refer patients to them, I'm sure they're like anybody else. Dan, Lance, Sabrina, we all like customers. That keeps us doing this stuff. So yes. Okay, and then let's see, this is a good question. Can we bill a one-time RPM setup fee?
So so I'll tell you what I have found. So if you are not Rural Health, you can bill the setup fee. With Rural Health, I have not seen it be paid. Dan, do you have something different?
I tend to agree with you. You know, if you go back to my soup pot, it's in the soup pot. They put it in there just for the averages. It pays $20 or 18 to $20 on the fee for service side. I find it hard to believe that CMS would pay you $72 to do that 20-minute setup. So I advise stay away from it. But again, I'm not a lawyer. You could make the case that why would they list it if they didn't want you to bill for it? So I wish they would just clarify a lot of these things. It's a great question, though.
Yeah, we'll find out. A lot of this stuff we're finding out as we go along. This is brand new in the scheme of things. You know, this just a lot of this stuff just started January 1 of this year. So last question.
Can I add one thing to that? Can document. I'm thinking under your GL 511. When you actually give the patient the device and you're going to educate them and you're going to make sure that they know how to use the device, you can document that as time that you're using it. I wouldn't go all the way up to 20 minutes. But if you spent 5 minutes going over that with the patient and education on that device, using the device, that is something you can document. I would not push it to 20 minutes, but it's going to count towards your 20 minutes for that first month.
Okay, that makes sense. Okay, last question here. To clarify, we can bill a CCM and a PIN in the same month. Example, they have 20 minutes spent in each one of those. I guess the answer to that is yes, you can do that, correct? You can. So,
yeah, just make sure you don't overlap your condition, right? So your PIN condition can't be your CCM condition.
Yeah, two different things. Okay. All right, I think we're going to finish up here because we got 20 minutes over our time. So thank y'all. This has been amazing. Very good. Very helpful. Everybody, we will send out the slide presentation, the recording, all of that will go out tomorrow to everybody that was registered. We had a little bit over 200 and something registered, about 140, 150 of you guys showed up. So thank you all very much for coming. Thanks to our speakers. Thanks to everybody behind the scenes. And y'all have a great weekend. Bye,
And I
everybody.
will,
Thank you.
based on your responses, I'll reach out to everyone who had further interest.
Yes, I'll make sure that you guys get a registration report too with emails on it. So you can go out. Yeah, so look. So if you attended or if you registered, look for some reach out from Dan and Lance and Sabrina. So thank y'all very much. Bye, everybody.
Thank you.
Bye-bye.
Bye.